Hello, and thank you so much for tuning in to today's presentation. My name is Dani Lloyd, and I'm joined here today by my colleagues Christine Rodriguez, Senior Program Manager at AIDS United, and Justin Kunzelman, Executive Director of Rebel Recovery, Florida. We are working with NASTAD's Health Equity team, supporting resource development for the Center for Innovation and Engagement. And today, we're here with you to present on emergency preparedness in the COVID-19 era and beyond. This presentation has been developed for harm reduction practitioners and programs that support their work with people who use drugs. So I'll be getting us started today and then hand over to my colleagues. First, we will review our agenda. So we'll take a look at the objectives for today's presentation first, and then I'll share some information about NASTAD and the larger project we are part of. And then we'll get into the nuts and bolts of our talk, which includes some background information to help set the stage for the discussion on emergency preparedness planning for harm reduction programs, and then dive into some promising strategies to help in that planning process. And then we'll wrap up with a spotlight on Rebel Recovery, a Florida-based harm reduction organization that has developed an emergency preparedness plan. So now on to our objectives for today's presentation. This webinar is meant to serve as a technical assistance resource to the Ryan White HIV/AIDS program and the broader public health community. The specific objectives of our webinar are to discuss the real critical nature of our work in harm reduction in a changing and unpredictable environment, be it the current pandemic or our changing climate. We will highlight the need to prioritize emergency preparedness in the harm reduction space, while also, of course, acknowledging that there are many competing priorities and it can be hard to carve out the time to devote to this process. We'll be sharing some research as well and providing some guidance and resources for developing an emergency preparedness plan of your own. So now, a shout out to our funders who made this work possible. So this project is supported by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services under grant number U90HA31882, Evidence-Informed Approaches to Improving Health Outcomes for People Living with HIV. The project is part of an award totaling nearly $5 million, with no percentage of funds financed with non-governmental sources. The contents of this presentation are those of the authors and do not necessarily represent any official views of, nor an endorsement by HRSA, HHS, or the US government. And if you'd like any more information, please feel free to visit hrsa.gov. Additionally, none of us presenting here today have any relevant financial or non-fiscal interests to disclose. And now I will move on to share an overview of the larger project. So first off, a bit of information about NASTAD. So who is NASTAD? NASTAD is the National Alliance of State and Territorial AIDS Directors. It's a national nonprofit entity representing public health officials who administer HIV and viral hepatitis programs funded by the state and federal governments. And NASTAD's mission is to end the intersecting epidemics of HIV, viral hepatitis, and related conditions by strengthening domestic and global governmental public health through advocacy, capacity building, and social justice. NASTAD works to interpret and influence policies, conduct trainings, offer technical assistance, and provide advocacy mobilization for US health departments. And the work of NASTAD spans all 50 states in the US, the District of Columbia, Puerto Rico, US Virgin Islands, 7 local jurisdictions receiving funding from the CDC, and the US Pacific Islands. So this began as a 3-year project and has been extended through August of 2022. And it's being carried out in partnership with Northwestern University's Center for Prevention Implementation Methodology and Howard Brown Health Center. The goal is to identify and promote evidence-informed approaches to engaging people living with HIV who are not receiving or may be at risk of not continuing to receive HIV care. And the result of this collaboration is CIE, the Center for Innovation and Engagement, which provides innovative evidence-informed interventions that support linkage, re-engagement, and retention in care to help end the HIV epidemic. So now I would like to show you just briefly an overview of some of the CIE resources, which you can access by visiting ciehealth.org. This is a really excellent sort of one-stop shop for resources that support evidence-informed approaches to HIV care. There are implementation guides and provider tools and videos and so much more to explore. So I encourage you to check it out and look around and see if you can find anything that would be particularly helpful to you in your organization there. There's definitely a lot to learn from that website, many resources. And I would like to now take this opportunity to highlight a few of the resources found at ciehealth.org. And both resources that I will share with you, you can find right on that website. So you can feel free to check out and explore on your own. So this first resource is addressing the integration of HIV and opioid addiction treatment with buprenorphine, which may be particularly useful to those of you who are interested in evidence-informed approaches to advancing health equity for people who use drugs. So this particular model, it's a model of on-site buprenorphine treatment, and it's guided by experienced HIV physician who is trained to incorporate more motivational interviewing techniques into routine medical visits to provide substance use behavior counseling. And then an HIV pharmacist facilitates buprenorphine induction, stabilization, and maintenance treatment with oversight by that physician. And this intervention integrates care into a single setting with a multidisciplinary team that facilitates practice, which is convenient for patients and also improves clinical capacity. So our next slide here highlights the Navigator Case Management Intervention resource. And this resource includes an implementation guide and an intervention summary and can serve as a resource for those who might be interested in implementing evidence-informed approaches that can advance equity for people living with HIV who have been incarcerated. So this is a 12-month-long intervention, and it's been designed for people with HIV who are incarcerated and returning home to their communities. The intervention takes a harm reduction approach and utilizes prevention, case management, and motivational interviewing techniques to promote healthy behaviors. Again, you can check out both of these resources on the website. And now on to our discussion on emergency preparedness. So we chose this topic to focus on today because it's really become an essential conversation in the harm reduction world as we've witnessed the sort of sweeping impacts of the COVID-19 pandemic and over time, the increase in frequency and severity of natural disasters. So these quotes kind of help to sum up the larger picture. This first one here is from United Nations Secretary General Antonio Guterres. Climate change is happening now and to all of us. No country or community is immune. And as is always the case, The poor and vulnerable are often the first to suffer and the worst hit. And this next quote is from a paper titled COVID-19 Lessons for the Climate Change Emergency. And it states, climate change can both facilitate zoonotic spillovers, or diseases that cross over from animals, and have an effect on transmission chains. These effects, alongside human behavior and awareness, need to be integrated in pandemic forecasting models. So I wanted to share these quotes because they do a good job of kind of reminding us of the larger story at play here, I think. And when having these discussions, it's quite important that we acknowledge that many of the root causes of climate change are also increasing the risk of pandemics. And many times when we're talking about preparing for one, we are also inevitably talking about preparing for the other. As we are well aware at this stage, across the globe, we're seeing an increase in the frequency of incidents that disrupt access to essential services. So things like healthcare, provision of food and clean water, basic sanitation, and so on. According to the United Nations Office on Disaster Risk Reduction, there were over 7,000 recorded disaster events from natural hazards worldwide over the last 2 decades. And according to the World Health Organization, COVID-19 continues to disrupt health services in some way in 90% of countries. Such disruptions can include things like impacts to livelihoods, so problems securing basic necessities, displacement from homes and communities, social implications, which have obviously been quite widespread during COVID as well and have taken the form of social isolation or physical distancing, and supply chain issues. So something like delays to shipping and delivery of food and medicines that might result in stockouts at supermarkets or pharmacies. And we've really entered an age where preparing for these kinds of events is not really optional anymore. And preparation will ultimately result in saving more lives and can increase the quality of life overall, while hopefully serving to sort of reduce that toxic burden of stress during times of crisis as well. And now here's a graphic I wanted to share from the paper I mentioned titled COVID-19 Lessons for the Climate Change Emergency. So this depicts hypothetical social and economic impacts of the COVID-19 and climate crises in both the presence and the absence of prevention measures. So as you can see on the 4 graphs, there are shaded red and blue areas. So areas of uncertainty are portrayed as those shaded areas around the curves. But as you can imagine, regarding both social and economic impacts associated with COVID-19 and climate change, impacts without prevention measures have the capacity to be far more significant and far-reaching than impacts with prevention measures. Now, as previously mentioned, population vulnerability plays an incredibly important role in who faces greatest risk. This, of course, includes people who use drugs. As the pandemic has progressed, we've learned just how catastrophic a toll it has really taken. And we now know that the loss of life due to overdose reached an all-time high in December of 2020. And undoubtedly, harm reduction organizations, other community-based programs, county health departments are the first to respond and bear the brunt of this work, despite often being understaffed and under-resourced. These entities really do form the backbone of community response. And we as a community need to identify ways to prepare despite these constraints. And we will start getting into that in just another slide or two. So any conversations around emergency preparedness must include ensuring the process that takes place is done in an equitable manner. As the authors of Health Risks Due to Climate Change, Inequity in Causes and Consequence rightly state, using an equity lens would facilitate moving beyond incremental adaptation and increase resilience and sustainability. So often emergency plans don't reflect the needs of many frontline communities, such as communities of color, low-income communities, LGBTQ folks, pregnant people, people with disabilities, incarcerated people. And these are the groups that are often most seriously impacted by disasters, but they are not always part of the emergency planning process. So it's really critical to include diverse perspectives in this process and ensure that you're providing the space for voices to be heard and contribute in meaningful ways throughout. And with that, I will now hand over to my colleague, Christine, who is going to be sharing findings from a recent study of harm reduction providers and sharing some promising strategies for developing an emergency preparedness plan of your own. Christine, over to you.
Thank you, Dani. I really appreciate it. And now we are going to be talking a little bit about syringe services programs specifically. And specifically syringe service programs as essential providers. So as syringe services staff know, SSPs provide a host of essential services for their participants and should be recognized officially as essential service providers by their local jurisdictions. Serving the most marginalized people who use drugs in our communities, many serve a de facto role as homelessness service providers, given the overlap between people experiencing homelessness and those who use drugs. They provide critical linkages to medical care, behavioral health care, and social services. They also bring to the work significant infectious disease expertise, often around HIV, viral hepatitis, and/or sexually transmitted infections. And this can be readily translated to other conditions, such as COVID-19. They also bring a really long history of innovation, as we've recently seen with repurposing fentanyl test strips for drug checking, or immediately adapting services to meet the community's needs in the era of COVID. As essential service providers, SSPs have been deeply committed to pivoting to provide continuity of services during COVID-19. So in conjunction with this global pandemic, we're seeing natural disasters as well occurring with increasing frequency, intensity, and unpredictability, like Dani mentioned, due to climate change. Now in 2020, Higher Ground Harm Reduction research partner Shareable produced a report based on over 50 SSP survey responses from around the country. Practicing harm reduction in a climate of disasters looked to better understand program needs and technical assistance preferences in the field in the event of an emergency or a disaster. Briefly, we'd like to share a few findings from this report. First, only 32% of SSPs responding reported having an existing disaster preparedness plan, and just 30% felt at least adequately prepared for a disaster or another similar systems disruption. Among the many impacts on harm reduction work that disasters may have, locating participants, participant access to services, and supply chain disruptions were among the most relevant for programs. Other key impacts included loss of funding and loss of staff, which is sometimes related to funding and other times, unfortunately, related to the crisis that we're experiencing, such as COVID-19. Let's talk about some promising strategies around emergency preparedness, particularly given the state of the field in emergency preparedness and harm reduction. Let's talk about promising strategies for mitigating the harms and impacts of disasters or other systems disruptions on programs and their services. First, the components of a planning process. Emergency planning is really critical in advance of a disaster occurring. While every program's plan will look different based on varied risk for different weather events, based on their geography, program structure, particularities of the clients that they serve, there are some common essential elements to the preparedness planning process. These include tailoring services to your specific context, participants, and staff needs, ensuring that the planning process is both purposeful and inclusive, and centers staff and participant needs and perspectives, particularly around workflow and a common definition of what safety really looks like for them. Revisiting your plan on a regular basis and making modifications if and when necessary, and addressing funding limitations insofar as there are opportunities to do so in your jurisdiction and or to seek funding opportunities to support and maintain some of the innovations in service that might be born out of necessity during an emergency. There are many templates and guides for writing an emergency preparedness plan online to support you, but some important components of your plan might include an introduction defining the purpose, priorities, and principles that underpin your plan, designating a response team, assessing your risk during different types of crises and disasters, continuity plans across preparation, response, and recovery phases, as well as a crisis communications plan. It's also particularly important to consider coalition building. Coalition building year-round is a vital component of preparedness work also, to establish partnerships, including those non-traditional partnerships, and have them in place already when you need them most. Some questions to consider in your coalition building include: what service gaps are there for participants during times of emergency, or which do you anticipate if you haven't experienced that yet? Given those needs, who do you need to be collaborating with now or in the future? And who else has touch points with your community and might be able to provide your organization and your participants useful aid? Consider engaging in service partnerships, mutual aid groups, pooling resources with other SSPs or other organizations to minimize the impact of supply chain disruptions, and consider partners that can help you communicate key information to participants. These can be informal, or you may want to develop MOUs or memoranda of understanding with other organizations to solidify your partnerships. Developing an emergency communications plan to relay key information efficiently and effectively is also really important, especially when new information may be emerging quickly and the situation on the ground is subject to rapid change. Ask yourself how you'll communicate key information like service or staffing changes to participants, staff, partners, and other key stakeholders like volunteers, for instance. In this process, you'll also want to identify trusted sources of information, such as the CDC for health information, perhaps FEMA for emergency alerts, or the National Weather Service. Consider communication needs and mechanisms for internal and external stakeholders. Consider the special needs of the community you serve. The CDC Special Populations Assessment Tool linked here can walk you through some of the considerations for this communication and give you some different ideas of potential barriers to think about. And also identifying and making explicit who is responsible for which communications and how the flow of that information is going to work and through which media. During an emergency event, particularly one that might be longer lasting or particularly disruptive, it is important for our participants that we monitor drug use and supply trends to identify emerging issues and adapt services accordingly. Ask yourself, your staff, and your participants whether or not this emergency is impacting the local drug supply, and if so, how. When exploring implications for your participants' access to their drugs of choice, consider issues of drug availability or limitations in access, new or particularly dangerous adulterants introduced into the supply. If you have access to drug checking technology, this may be a particularly important time to utilize it. Any shifts in drug use patterns due to the above, or changes in routes of administration among your participants. Emerging issues from the above, such as new or increasing health needs due to, say, adulterants or withdrawal or other issues. As we discussed earlier, during a disaster event, many programs identified being unable to locate participants or participants being unable to access services as key barriers. If your program operates out of a brick-and-mortar fixed site model only, it may be advantageous to explore offering alternative access to services, particularly for safer drug use, safer sex, and hygiene supplies. Some options to consider include mobile services using a vehicle, bikes, or street outreach, on-demand delivery or mail-based services using a dedicated warm telephone or text line. Any telehealth options partners may be able to offer, so there are fewer visits to make when folks need healthcare. Building your network of secondary distribution partners among your participants, which are things that we're doing anyway, right? To reach greater numbers of folks who may not be able or willing to access your services otherwise. Advocacy. Advocacy is often part and parcel of harm reduction service organizations, and it's direly needed in and after times of emergency as well, as new issues or opportunities may emerge as a result. One great example is the hashtag Peers in the Pandemic campaign, created by the International Network of People Who Use Drugs during the COVID-19 pandemic, which seeks systems reforms, including declaring harm reduction as essential, allowing workers to continue services through general population lockdowns, expanding and maintaining take-home doses of methadone or opioid agonist treatment, which became allowable in the United States post-pandemic, prioritizing and adequately funding peer-led responses, removing punitive measures in harm reduction, because we know punitive services are not really harm reduction to begin with, right? And a call to action to act now on decriminalization. So now that we've set the stage and reviewed some promising practices, I'd like to turn it over to Justin Kunzelman, Executive Director of Rebel Recovery Florida, to speak more specifically about their emergency preparedness activities.
Thanks, Christine. My name is Justin Kunzelman. I am the Executive Director and co-founder of Rebel Recovery Florida. Rebel Recovery is Florida's first peer-founded and led recovery community organization supporting people who use drugs actively or those in or seeking recovery. It was founded in 2016 by my co-founder, Nancy McConnell, and I. It was founded out of our direct lived experience as individuals receiving services in Palm Beach County, Florida, for public assistance regarding chaotic drug use and experiencing homelessness, food insecurity, job insecurity. So we built our programs on the basis of our experience across over 30 years of shared experience. We founded it with the sole purpose of providing services to people who use drugs, those in or seeking recovery, and really wanted to create something that valued complex personhood, the right to choice, and believed that any positive change should be considered recovery. Our mission is Rebel Recovery Florida is a low barrier recovery community organization that provides recovery support services, education, and advocacy to people impacted by drug use and those living with or at risk of HIV and AIDS. Our vision is a Florida that values the lived experience of marginalized and or oppressed communities in the funding, development, leadership, and delivery of supportive services for people directly impacted by drug use. During the course of our services as a direct service provider, a large part of our, I guess, the foundation of our work and a lot of the framework of what we do is built upon developing trust and a shared lived experience with our participants. Part of that trust we found early on came in the form of developing strategies for people in emergency situations. A lot of the work that we do is considered done in very acute emergency situations, but we also had to look at I think the first thing that came across was a hurricane came, and we had to, for the first time, we sat and talked about what types of things would be needed for our participants, and what types of things did we need when we were experiencing homelessness, experiencing food scarcity. We had no access to stable housing. Our county still does not have a homeless shelter of any sort. What we do have in abundance is hurricane shelters. So we really had to identify, like, how do we provide services for people within the scope of an emergency situation, like a natural disaster, and when an infrastructure for that really doesn't exist. So we had to look at the development of an emergency preparedness plan, and we took pieces from different policies and procedures that we had, and brought them together, and we looked at different policies and plans from organizations that requiring accreditation, like JACO, CARF, large healthcare accreditation organizations, and looked at what they required and kind of put it all together to meet the needs of what a harm reduction program, or a program operating on the harm reduction principles, would need to provide services and complete wraparound services for their participants in times of crisis, trying to create a comprehensive plan. So when we originally looked to develop a plan, we looked to outline what were our preparations, to put in black and white, what preparations did we make as an organization to respond to any given number of emergency situations that could occur during service provision or during the daily course of operations. What about after hours of service provision? What about outside of our operation? How far did that responsibility extend for us to prepare individuals for these emergencies? Most of the time, agencies' emergency preparedness plans generally talk about what the staff is going to do. It guides the staff in their responses to setting up or responding to an emergency situation. A lot of different components can generally make up an emergency preparedness plan. We can have various different policies from various portions of our policy and procedure manual or standard operating procedures that can be brought together and put under an emergency preparedness plan. So they may appear twice in our policy book. Generally, these policies would cover medical emergencies, fire, terrorist acts, loss of power, or man-made or natural disasters. The terrorist acts seems like, at least when we were creating ours, it seemed like a very odd thing to include in a little community grassroots-based organization. But unfortunately, it's a part of requirements for a lot of federal funds, and for a lot of state funding, which is funneled down through federal funds in response to 9/11 and the Patriot Act. A little bit like drug-free workplace policy, and that it just needs to be there. They need to know that you have an idea to respond to these things, though it doesn't outline specifically what things need to be covered. Ours covers under terrorist acts, it covers suspicious mail, potential explosive devices, any powdery substance, pretty much anything where that would involve a person intentionally trying to harm other people is considered under the terrorist policy. Natural disasters is obviously inclement weather, hurricanes, tornadoes, earthquakes, fires. Medical emergencies obviously cover everything from minor scrapes and cuts in the office, where we would just locate the first aid kit, to now with the emergence of COVID, protocols for viral infections and potential outbreaks of very contagious diseases. Emergency preparedness plans can help save lives and money by lowering the rate of remuneration, the cost rate per $100 of payroll, with workers' compensation insurance carriers, and are often included as part of a risk management plan, which helps to reduce the insurance rates for organizations. There's more positive benefits than just the preparedness. There's also fiscal benefits for organizations who may not have emergency preparedness plans, or may not be thinking about emergency preparedness plans, to simply look at risk management plans and emergency preparedness plans is something that can be submitted to help lower the cost that they have to pay, just as like the cost of doing business operation expenses. Medical and first aid emergencies. I just wanted to define a few of the types of things that are covered in Rebel Recovery's emergency preparedness plan. And some of these will be pretty standard across all emergency preparedness plans. Some of them, as we'll see, maybe more culturally specific. So medical and first aid emergencies cover general illness, injury, all the way up to other medical emergencies, heart attack, things like that. Staff and participant medical emergencies are explicit procedures for dealing with staff or participants of the program that are suffering from medical emergencies, whether they be minor, meaning non-911 related, or 911 not needed to be called, sickness, injury, scrapes, cuts, bruises, where's the ice packs located, where are the first aid kits located, where are is there a plan in place for time off, or for if somebody gets injured to have their responsibilities covered, things like that, up to major requiring call of 911 or other immediate medical attention. These procedures specifically should be, I mean, all emergency preparedness plans should, but these procedures specifically should be discussed with staff participants on an ongoing basis, including fire drills, what to do in case of hurricanes or terrorist acts. A large reason for that is that programs serving directly impacted populations, for example, people who use drugs, BIPOC communities, specific attention should be paid to the potential negative impact of calling 911. It's been our experience that sometimes calling 911 can make things worse, that generally the participants of the program should be informed that 911 is going to be called because of said emergency. Educating the staff and the participants up front about these processes just saves an awkward conversation for later, for people who may be negatively impacted by the presence of police or medical emergency personnel, specifically in populations of people who use drugs, just given the volatile nature of our general experiences in those types of settings. So we try to talk to our participants and our staff on an ongoing basis about, hey, if there's a fire, this is what we do. If you're here and there is a hurricane, here's what we do, so on and so forth. They're very They can be anywhere from very scheduled, official, documented trainings and drills to very casual type of just, hey, we have our emergency preparedness plans, and let's contact our participants to let them know what's going on in regards to, say, a hurricane or something that's where we have pre-warning. Human and natural and human caused disasters vary depending on the geographic location. I'm in South Florida, so we deal with hurricanes and tornadoes. I would have no idea what to do during an earthquake, um, uh, a blizzard, anything like that. If my road froze over, I would just stay home. I don't know what the preparation for that looks like. I don't know what a show snovel looks like. Um, it's it's very specific information regionally to Florida. That most people who live in South Florida know what to do in the event of a hurricane. So these are not things that are set in stone. Different geographic areas or locations, uh, different areas are going to have different things that they need to respond to. It's something that should be seen as more like a living document than necessarily just a static um, uh, type of policy that just exists in this current state forever. Um, so uh, this covers any potential natural or man-made disaster not previously covered, and it also fire is put under here in general. Fire safety drills, location of fire exits, and evacuation plan that has been approved generally by um, fire marshal, or whoever the inspector is for the buildings for the county. Um, there are specific fire extinguisher codes and colors that are covered under this to identify how to respond to different types of fires, whether it be a small grease fire, a small fire with a accelerant, or if it's just, hey, someone dropped a lit match on the ground. So uh, most places keep a logbook of fire drills, the equipment inspections, building inspections, and locations of location and condition of fire safety equipment. It's generally mandated by either the county, the state, or the city or town that you're in. Although some states like Florida, nonprofits are exempt from having to get specific certification every year. We just need the one for insurance purposes, and that's it. Hurricanes, again, this is a regionally specific example, but it's what I know, so it's what I'm going with. This covers the response to hurricanes. It identifies shelters, food banks. It outlines the warning system. What is a tropical storm warning? What is a tropical storm watch? What is a hurricane watch or hurricane warning? What are the categories of hurricanes? What are the potential impacts of this? It outlines participant and individual planning steps, and steps to ensure clear lines of communication between staff, and provides resources for impacted staff and participants. So these are things that should pretty specifically be identified: paid time off, insurance claims, staff illness, injury, participant illness or injury. In our specific situation, we developed a emergency follow-up form that we call each of our participants that are on the peers caseload. We ask them if they know that there is a hurricane or a tornado or tropical storm warning or watch, and have a form of questions that we developed just to ensure that they have access to the things that we spoke about before, that they have access to a shelter, to a stable source of food throughout the emergency. And these responses are recorded, and then follow-ups are done with the participants. Generally, we try to balance out the need to respond to participants' emergencies, and also to give enough time for our staff to prepare themselves in their homes. So these types of things can be very tricky in terms of service delivery. From a strictly objective standpoint, there should be a 50-50 balance where executive directors and leaders are taking care of both the staff and the participants, recognizing the given time needed for a staff member to take care of their own home. And sometimes that looks like paying people to board up your staff's windows in their own homes and prepare their homes for them so that they can help the participants prepare. Those are things that should really be pre-discussed, predetermined, so that when the emergency comes, that everybody's not scrambling to try to identify what to do in a given situation and whose responsibility is what. So the basic idea of all emergency preparedness plans is really to prepare for emergency situations and to try to pre-identify any questions, concerns, crazy thoughts, ideas, anything that can be put together beforehand, so that in the time of crisis, we've practiced this, we've talked about this, we have it written down, we know exactly what we need to do, so that cooler and calmer heads prevail, and we can ensure that nobody gets left out, left behind, or gets left unprepared. Thank you. I will give it back over to Dani.
Justin, thank you so much. That was such a great overview of all the work you're doing at Rebel Recovery. It was really great to hear that. So I'll just wrap us up quickly now with, I'm going to just run through this list of resources pretty quick. I just want to highlight a few of them for you. So first here is this great toolkit, super comprehensive, created by the NAACP's Environmental and Climate Justice Program. So this toolkit is equity focused, really helps with bigger picture emergency preparedness planning. I really encourage folks to check it out. Next on the list is the Higher Ground Harm Reduction and Shareable report that Christine had worked on and shared with us today. It's an excellent report and encourage you to check that out too. So I won't go through the rest of the list, but just encourage folks, if you have the time and you're looking for more resources, there are so many out there that can that helped inform our presentation today, and that could certainly be of use to you as well. So including resources from the Global Commission on Drug Policy, the International Network of People Who Use Drugs, which Christine had shared some information about earlier, and then of course resources from Vital Strategies and AIDS United. And then this is our list of references, of course, plenty more for you to explore there as well. And that is the end of today's presentation. Thank you so much from myself, Christine, and Justin. It was really lovely having this opportunity, and hope you enjoyed all that we have to share. Thanks again.